Hi everybody. So today we're going to be learning about addiction medicine. But I guess the first thing that we should learn is that you're not supposed to really use the word addiction anymore. You're supposed to use substance use disorder or opiate use disorder. So that's going to be like UD, OUD, or SUD, substance use disorder. All right, we have some people arriving. That's lovely. Okay, so the mainstream addiction treatment, see, they even use the word addiction there. It's called the MAT Act provision, and it updates federal guidelines to expand the availability of evidence-based medicine to address the opioid epidemic. All right, so the acronym there is MAT. Shri,
Yes.
wink, wink, nudge, nudge. So there's going to be a test about all this. So I think that the first thing that I'll just give it away. The first question on the test is going to be the acronym for the mainstream addiction treatment. So MAT, you can remember it like a yoga mat. So yes, it's MAT. All right, so that is something that's really big, especially for physicians now, and it's because the opioid epidemic is pretty serious. Does anybody have any idea how many Americans meet the criteria for opioid use disorder? Just, give me a ballpark number.
Like 10%?
All right, so, well, actually, that's pretty decent. All right, so I think there's like 300 million Americans. So to get a percent, we'll have to calculate. I think it's more like 1%, but I think 10% was a good enough answer. I like that. So it's actually going to be 3 million Americans and 16 million people worldwide meet the criteria for opioid use disorder. And that's just opioids. It's not taking into consideration other addictions. What are some other drugs that people could be addicted to? Not necessarily even illegal drugs, just even legal ones that you guys probably had this morning.
Coffee?
Caffeine, not coffee itself, but the caffeine in it. Thank you. This is supposed to be an interactive lecture. Okay. So yeah, caffeine, not necessarily coffee. And then what are some other ones, like really easy ones? They serve it at bars.
Yeah, I was gonna say alcohol.
Yeah, alcohol. Okay, so let me just see who's all in here so I know. If anybody is not here, you have to watch it and then take the test later. So let me just check and see what our attendance rate is like. I'm going to screenshot it at the beginning and at the end to see if anybody disappeared. So just hold on a second. All right, we have some new special guests arriving. All right, so Shrey, can you tell if it's recording?
Yeah, it is.
Okay. All right. So we have more people in here now. So just to recap, because the answer to the first question that I gave away was MAT. And for those of us who were here, what did MAT stand for?
Mainstream addiction treatment.
Yes. Mainstreaming addiction treatment. And what was the weird thing? Because they used the word addiction, did I say at the very beginning? You're not supposed to use the word addiction anymore. So ironically, it uses the word addiction. What are you supposed to use instead of addiction? Substance use disorder. Okay. It's a good thing I'm teaching you guys. Okay. Now, what exactly is the definition of the substance use disorder or opioid use disorder? So let's specifically talk about opioid use disorder. So you got to have 2 or more of the following items within 12 months. All right, you got to have continued opioid use despite worsening of physical or psychological health, or continued opioid use despite social and interpersonal consequences. Another one is decreased social or recreational activities. Another one is difficulty fulfilling professional duties at work or school. So if you're using opioids and you can't get to work or can't get to school, you would check that one off. Excessive time taken to obtain or recover from taking opioids. So if you're spending most of the day on the street trying to get opioids and you're not able to do anything else, that would count. Or if you are having such terrible symptoms in regards to the opioids that you can't function, that would also count for that one. You take more opioids than you intended to, you have cravings, you want to stop, but you can't decrease the amount. And then you have a tolerance that builds up. What's a tolerance? Tell me none of the people here know what tolerance is.
I think I'll go ahead and try. My understanding is the tolerance is the ability to build up a resistance, not a resistance, but to kind of endure more of like a drug without an adverse reaction.
Yeah. I understand what you mean about without an adverse reaction. I mean, ultimately, if you have too many, you'll die. But I know what you mean. So you have to take more in order to get the same effects is the definition of tolerance, which you are pretty much on point with that answer. All right, so if you have tolerance, that counts as one of the criteria. And another criteria is that you continue to use the opioids despite the fact that it is posing danger. And the last criteria is that you have withdrawal. Does anybody know the difference between an effect and a withdrawal? I'll give you multiple choices. Does withdrawal happen while you're taking it or after you're taking it?
After?
Correct. After you stop. That is a withdrawal effect. All right. If you have 6 or more of the things that I just named, then that is severe opioid use disorder. Okay, now withdrawal from the opioids. Again, because this is very important. Hint it. Well, I guess I can't hint to Shree without hinting to everybody. Let me bring up like a private chat on the side with Shree so that every single test question isn't going to be. Shree, are you on your email?
Yeah.
Well, I'll just email you. Nobody's gonna tell every time I start typing. Can you see me? Like in live time so that I can just like ping you
Yeah.
every single time I say something that's gonna be on the test. Because I don't want to stop and be like, Shree, write this down as an answer for the test. Okay, well, it's kind of obvious that the next test question is going to be about withdrawal. So anyway, just to recap, does withdrawal happen while somebody's using the drugs or after they're done?
After they're done.
Yes, after they're done. And specifically with opioids, the withdrawal are aches, diarrhea, runny nose, excitability, and chills. And it's pretty horrific. People feel really bad. I've seen it frequently working in inpatient psychiatric units. It is not a pleasant thing. Okay, now pop quiz, I guess. Pop question. Who do you think is more likely to become dependent on opioids, men or women?
Men? Question mark?
Yes.
Yeah, I was gonna
Yes.
guess men as well.
It's men. The answer is men. All right. And so it's very prevalent. We talked about the criteria. We talked about the NAT Act, which is federal guidelines. And one of the things for physicians to know is that they eliminated the data waiver, the X waiver program. It required the prescribers to have a specific prescribing authority to prescribe a treatment for opioid use disorder. That treatment being buprenorphine, but they got rid of it, and the idea is now to make it so that more providers can actually prescribe that, so that it will be able to treat more people with opioid use disorder. So this is all regarding laws and recent acts of the federal government pertaining to addiction, which you're not supposed to use that word. You're supposed to use this is say it again.
Substance use?
Yes, substance use disorder. Thank you. I mean, everybody's still going to use the word addiction, so I don't. I'm just letting you know what you're supposed to say, not what people actually do say. Okay, so we talked about the MAT Act. The MAT Act, okay? And then we have the opioid dependence. And what kind of things do you think go into being dependent on opioids? I'll give you a hint. It has to do with literally everything. There's two things that determine pretty much everything about you. Nature versus nurture. Anybody know? Anybody ever take a science class before? Your genetics and your environment? No one's ever heard of this concept? Does anybody know what DNA is?
Well, yeah.
Okay. All right. So the predisposition to becoming addicted would be a.
Like a genetic factor?
Yes, that is the word I was looking for. A genetic factor, but also, what's the other word? It starts with an E. It's usually the opposite of genetic.
And
Environmental?
Yes, environmental. So there are both genetic and environmental factors at play to opioid dependence. All right. And we talked about the prevalence, and it causes about 47,000 deaths in the US. And again, I'm just talking about opioids. I'm not getting into any of the other substances you guys named, alcohol and caffeine. But of course, there's like cocaine and PCP and marijuana and ecstasy and crocodile and K2 and things you guys have never heard of. There are all kinds of drugs. The 47,000 deaths per year in the United States is opioids alone. So you can imagine with all the substance use, that number only gets much higher. Okay. So we talked about these different things to look for. So let's say you guys have a patient that you think could potentially be abusing opioids. What kind of questions would you ask in order to determine if that is the case?
I think I would ask if they ever take more than they initially meant to of an opioid,
That
Or-
is a perfect question.
or maybe like, do you still get this, like we were talking about with tolerance earlier, if you get the same effects from the same amount, or if you have to take more on purpose to get the same effects?
Precisely. Now on my Zoom, it's not telling me whose name is what, but I can tell that that is Riley's voice.
Yeah. It was me.
Thank you, Riley. Yes, the literal word for word recommendation that it says for physicians to ask are, do you have to take more opioids than intended? Which is literally what you said, Riley. You don't even need to take this class. No, I'm kidding. Please stay. Okay, exactly. The tolerance and taking more. And then one of the things that I ask that I find to be very important, because one of my keys is always safety, is I ask if they've done anything either while under the influence of the drug or in an attempt to obtain more of the drug. Did anybody get hurt, or has anybody, you or yourself, been put in a dangerous situation? Right? Because that's the most extreme. Of course, secondarily, I would ask, like, has it affected your ability to do your homework and get your chores done and get to work on time? Because that's still hindering somebody's life, of course. But number one, it's like, Were you driving while high all over the road? Like, both of these things are not good, but the most important one is going to be danger. Yes, it's not good if you're failing your science class because you're on drugs, but it's not as horrible as if you were like babysitting the neighbor's kids and doing drugs, and then the kids were like wandering out into the streets and stuff. Like, it's all about safety and danger, but either one is a warning sign. Okay. So you definitely want to talk to your patients and ask them, like, how are they getting it? Is it dangerous? They probably have to be hanging out with shady people, unless of course they're doctor shopping. Does anybody know what doctor shopping is?
Going to a bunch of doctors and getting drugs from a bunch of doctors.
That is exactly right. Now I check in the state database if somebody has had controlled substances from somebody else, but clearly not many doctors do, because I frequently find that they've been to 8 other doctors this same week. So usually doesn't slide by me, but some doctors don't check. And if you go to enough of the doctors that don't check, you ended up getting tons and tons of opioids. So I check. Let's see. So oh dear. You want to check the safety. You want to check the ability to function in everyday life. Is it destroying your relationships? Are people around you telling you that you need to stop? That sort of thing. Okay, so the majority of patients actually get addicted to the amount of medication that they're prescribed. A lot of people think that they get addicted when they start taking more than is prescribed, but in the majority of cases, it is, I don't want to say just what they're prescribed, but I guess that word makes sense. It's just what they're being prescribed is what they get addicted to. So it's not like most of the people that are addicted got addicted because one day they're like, I'm going to take a double dose. The majority of the people got addicted because of like the dose that they were given by their physician. Let's see. So there are different treatments for different types of addictions. This is going to require everybody to know the difference between an agonist and an antagonist. Does anybody know the difference between an agonist and an antagonist? I know you do. I guess my question is, does anybody want to say out loud the difference? Y'all, it's so
You
important.
might be breaking up a little. Could you say that again?
What's the difference between an agonist and antagonist?
One kind of like excites the system, but another would turn it off more.
Yes, an agonist acts as the drug and an antagonist goes against it. All right, so let's think of some examples of treatments for different drugs that are agonists and antagonists. So if you are helping your patient quit nicotine and they're smoking and you want to help them quit and you give them nicotine patches, is that treatment an agonist or an antagonist?
I want to say agonist.
It is an agonist because it's literally nicotine. It is doing the same thing, right? Does anybody else know any medication treatments for
Can I
any
ask,
drugs?
like, how, like, since it is nicotine, like, how is that, like, approved or, like, allowed, basically? I'm just curious.
Well, it was created to get people to stop smoking, not not to get people to start smoking.
Okay.
Um, does anybody know any other treatments for any addiction?
I've heard of like the extreme form, like for overdoses, like naloxone or something like that.
Oh my goodness, thank you. Yes. And so is that going to be an agonist or an antagonist? If it is an antidote, if anybody remembers the poisons and antidotes lecture, that is going to be Narcan is an antidote. So is the antidote going to be an agonist or an antagonist?
Antagonist?
Correct. It reverses opioid overdose. So that's an example of a treatment that is an antagonist. So nicotine is an example of a treatment that's an agonist. Narcan is a treatment that is an antagonist. Does everybody understand the difference between agonist and antagonist?
Dr. Waggel, I have a quick question.
Sure.
All right, so I was wondering, is it possible treatment for an addiction just the addictive substance, but in like a smaller quantity to help with withdrawals?
Yes, that is what's called a taper. And I talked about that a little bit further on. So, like, let's say you're on 10 milligrams of some addictive thing. The doctor will next week help you go to 9, and next week help you go to 8, and next week help you go to 7, and so on until you're off of it. And that is called, ladies and gentlemen. Actually, I don't think there's any gentlemen here. Are there any gentlemen here? That's a taper. Very important. So yes, I suppose the treatment could be the drug itself. That is a great question. Now, here's a tricky one. Is buprenorphine, which I talked about earlier, an agonist or an antagonist? I'll give you a hint. It's tricky. Guys, it's both. Okay. Let's see. So I suppose we'll just jump to naltrexone versus naloxone. Does anybody know the difference between the two? You're allowed to say no, at least you'll be participating.
I have no idea, Dr. Waggel.
Ah, the honesty. Bonus points for honesty. Okay, so naltrexone and naloxone both treat opioids. Naloxone is a medicine that reverses the opioid. It's the Narcan. It's the one that Shree brought up. So if you recall, was that an agonist or an antagonist? We just said it 3 minutes ago.
Antagonist?
Correct! It's an antagonist. Great. Okay, so it does the opposite of what opioids do, right? Okay, so you have naloxone. It is an antagonist. It reverses it. It's the antidote. You should carry some around with you because apparently a lot of people, young people in this area, and I guess all over the United States, are overdosing on opioids. And fortunately, a lot of teachers and people at school are carrying the Narcan, and that is saving lives. The nasal spray is one route, I suppose, that people would be most comfortable with, and it's also available in an injection, and it works pretty quickly, and it reverses the overdose. And it lasts about 30 to 90 minutes, which is long enough for EMS to get there and help your friend out. So having naloxone, aka Narcan, on you is probably advisable just because of the prevalence of people overdosing from opioids. On the other hand, we have naltrexone. The common names of naltrexone are Vivitrol, and you use that to help people with their cravings. And you can have a pill of that, and you can have like capsules. And let's see, it works for about 24 hours. And you could inject it, which lasts for 30 days. So if you have a patient that is sure that they want to take it now, but thinks they might change their mind, you can offer them the one that lasts for 30 days. All right, so does somebody want to repeat back to me the difference between the naltrexone and the naloxone? All right, how about I ask you questions and give you a 50-50 shot? Was the naltrexone or the naloxone the Narcan? 50-50 shot.
Naloxone.
Naloxone is Narcan. Is the naltrexone or the naloxone Vivitrol? Remember, all these medications have to have multiple names. That's the joy of pharmacology, everybody.
A naltrexone.
Yes, naltrexone is Vivitrol. All right, so naltrexone is an antagonist. Okay, and naloxone is?
An antagonist?
Yes, it's also an antagonist.
Okay.
Yay! See, you guys are paying attention. All right, which one comes in injection and nasal spray?
I think naloxone is the nasal spray.
Correct, Amungo. That is exactly right. All right, so if you have a patient that comes to you and they say, "Hey doc, I need help with my cravings for opioids," which one do you prescribe?
Naltrexone. It's more.
Right, right. If you have a patient that comes to you and they're not breathing because they took too much opioids, which one do you give them?
Naloxone.
Oh, that's it. Okay, so do we know the difference between naltrexone and naloxone now?
I think so.
Okay, that's very good. Okay, so we talked about agonists and antagonists, and methadone is another treatment that was more popular in the past. You have to go to an actual like methadone clinic. It's a little bit more involved. It has EKG issues like QT prolongation. It's just still used, but not as trendy as it used to be. And what are, you guys aren't going to know this, but I'll ask it anyway. What are some treatments for stimulant use disorder? So your patient is no longer abusing opioids, they're abusing stimulants. I know you guys don't know this. The answer is Wellbutrin and topiramate. That's okay. And what are the acronyms, 3-letter acronyms for the contents of marijuana?
THC.
Yes, and another 3-letter acronym.
That's all oh, CBD.
Oh, yes.
Okay.
Okay, so we have in the United States, sativa and indica. Sativa has higher THC. THC is energizing and it makes you hungry. Indica has more CBD, also makes you hungry, not so energizing and makes you sleepy. And it's like for pain and muscle relaxants. Okay. And I don't know if this is true, but this is what the lecturer from the federally mandated program states, that the number one reason people use cannabis is to alleviate cannabis withdrawal. I have a feeling if you polled the general population and asked them what the number one reason they use cannabis is, they would not reply to alleviate my cannabis withdrawal. But that is what the lecturer said. So that's what I'm teaching. What do you guys think people would say they use cannabis for? Don't overthink this. Let's just say you walk out onto the street, and if you're in Alexandria walking on the street, half of the people walking by you will be smoking a joint anyway. So let's just say you ask 10 of them, why do you use marijuana? What would they say?
I think they would say that they like it and they like to get high.
Yeah, probably. They'd be like, I like to be chill, or I feel good, or yeah, whatever. But the guy, which, I mean, maybe they want to be chill because they're alleviating their cannabis withdrawal. It's just what I was taught is the number one reason people use marijuana is to alleviate their cannabis withdrawal. However, I still surmise that if you took a census of the general population, very few people would give that as the answer. Okay. Let's see. The controlled substance contract. So if you are a doctor and you are prescribing controlled substances, do you think it's better to have a contract and go over a few key safety features, or do you think you should just prescribe it and not talk about it?
I think the contract sounds like a good idea.
Yes. Okay, so you're supposed to have it and get them signed. You're supposed to talk about the risk factors that we talked about earlier, which there were two things. One starts with a G and one starts with an E. Nice.
Your
Guys.
genes and your environment.
Genetic and environment. Correct the mungo. So you're going to talk about for genetic, the family history. Does anybody in your family have any opioid use disorders, alcohol use disorders? Has anybody ever had alcoholism so bad that they had liver disease? So then you can establish the genetic risk factors, then environmental risk factors, how much support they have in their community, what's going on, is everybody around them using oxycodone? And so after you have this conversation with your patients and hopefully discover they have a low risk, then you can go over the contract for prescribing pain medication. Usually you want to make sure that they've tried some non-opioid treatments for pain, like physical therapy, or depending on where their pain is, like a knee brace, or things that you won't get addicted to. I've never seen anybody become addicted to a knee brace, although I guess psychologically you could get addicted to anything. But before jumping to opioids for pain relief, you want to try some other things. So this is just this is way over y'all's heads, but I'm still going to talk about it anyway. There are liver enzymes called, well, one of them is called CYP2D6. I didn't name it. Don't look at me. There's a 10% of the Caucasian population doesn't even have this liver enzyme. It breaks down codeine into morphine. Are you guys familiar with drugs and medications and things, and the fact that liver enzymes break them down into byproducts? Is this a concept that is foreign to everyone, or do you know what I'm talking about?
Definitely familiar, just not that specific, like
So
interact.
metabolism, yes, yes. Okay, so if somebody doesn't have the liver enzyme to process the codeine into morphine, when you do drug tests, they might not have the byproduct. Now, there is an interesting way to not get the metabolite. It is a concept called shaving. And no, I don't mean your legs. Shaving is when your patient knows that they are going to get a drug test. Okay, maybe I should back up because you probably are all assuming that you want them to get negative in their drug test. You want them to have a positive drug test because you're the one prescribing them opioids. If you are prescribing somebody opioids and you drug test them and their urine does not indicate that they've been taking opioids, what do you fear is actually happening to those opioids that you are prescribing?
Someone else is taking them.
Correct. Your patient is selling them. So now that we've established the fact you actually want your patient's drug test to be positive for opioids, now I can go to the next part. Shaving. Your patient knows that you are drug testing them for opioids, and they need to be positive for opioids because you're prescribing them opioids and you want to make sure that they are the ones taking them. They may engage in this process called shaving where they put the opioid directly into their urine. However, you're a doctor and you can tell if they're doing that based on the conversation that we just had about metabolism and byproducts. Think outside the box here. You're a doctor. You're testing your patient for opioids because you're prescribing them and you want to make sure that they're taking them. You're looking at the urine. You think that they're not taking the opioids, but it came back positive for opioids. How can you tell if they are engaging in this process called shaving?
I'm just gonna guess here, but I feel like can you like see it in the pee if it hasn't dissolved all the way, if they just sprinkled it in?
That is not the answer, but that actually probably could be true. If you take somebody's urine and then half of a pill is dissolved at the bottom of it, you can probably be safe to assume that they dropped the opioid directly into the urine, which I like that answer because it's so obvious. So yeah, 1,000 points. Who said that?
That was me, Riley.
Oh, how could I not tell your voice? Anyway, Riley, 1,000 points to you.
Thank you, Dr. Waggel.
Yeah, I mean, if you look in there and there's like half dissolved pills, then you can know that they are putting the opioids directly into your urine. But an even more sneaky way to know is that if there are no metabolites in the urine. Does that make sense to everybody?
So I have a question about that then. Like, if let's just say theoretically someone knew they were about to like go into a drug test and they took an opioid like right then, like right before taking the drug test, then would it show up?
Well, it wouldn't matter because they're supposed to be taking them every day.
Right, right. But like, would you be able to tell if they had just taken it that one time because of the number of metabolites, or?
Are you most people when they talk about drug tests are not getting drug tested because they want it to show up positive. In these cases, we're wanting it to show up positive.
Okay, yeah.
Are you asking if the doctor can tell what time they took the opioid?
I mean, I'm saying like, let's say someone was like selling these opioids or whatever, right? And then like, but then they find out like they have to take a drug test and it has to be positive, like as a theoretical, and then they take one right then and there, like right before like peeing in the cup.
I do not. That's a good question. I do not know. I would assume it would take. My guess is at least 30 minutes. You would need to take it at least 30 minutes before you pee, but I don't know the exact amount of time. So that's a great question. Um, but if you took it at the same time, like you're about to go and pee, it wouldn't show up.
Okay, that makes sense. Cool. Thank
All
you.
right. So if the metabolite's not there, maybe they're shaving. All right. And so this is really tricky because people, it's a sensitive topic. I don't know if I talk to people and tell them that I suspect that they're abusing drugs and they're like real nice about it. It's just, you have to, you can't be judgy. From my standpoint, all I really care about is their safety. And so I need to convey to them that it's not like, oh, like I'm cool because I caught you doing drugs. It's like, yo, I'm your doctor and I'm like worried that what you're doing is going to end up killing you, right? And it's very important, but also very difficult to convey to them that your main priority is to keep them safe. So you just have to somehow, it's like you have to call them out. People don't like to be called out, but it's like you need to convey that the only reason you're doing that is because you don't want them to die. Like, it's just, you have the years of practice it's a really hard conversation to have, but you have to be non-judgmental and you have to really focus on the main objective, which is to keep people from getting addicted to stuff so that they don't end up OD'd. All right, so here's a fun one. You are prescribing these opioids and your patient is pregnant. Man, what would happen if you just discontinued the opioid?
Withdrawal.
Withdrawal, yes. And do you think that opioid withdrawal is good or bad for a baby?
I think it'd probably be pretty bad, Dr. Waggel.
Yes. Yes. That is exactly right. So if your patient, somebody's calling and now my Zoom is all goobered up. Am I back? Okay. So if you're prescribing opioids and your patient comes in and says that they're pregnant, you're not supposed to just say, okay, no more opioids, because opioid withdrawal can affect the baby. There is something called neonatal opioid withdrawal syndrome, also called NOWS, and there's also neonatal abstinence syndrome, also called NOS. You don't want the baby to have either one of that. Okay? It leads to irritability, seizures, and weight loss. Okay, so you want to taper at a 5 to 20%. The Veterans Affairs has a good chart for opioid tapers. However, the CDC says that it's pretty much entirely dependent on the patient and you can't just follow like some algorithm, right? Like, so for me, like I always do things like based on the patient's response, not based on some chart that I downloaded from the internet. So you can try to follow the chart, but you also have to respond to what the patient is experiencing. Needless to say, you don't just stop a pregnant woman's opioids. All right. However, if you want to keep prescribing it, there are also bad things that can happen. So with the opioid withdrawal, there can be premature labor and spontaneous abortion and all sorts of things. And by the way, I have to clarify that when doctors use the word abortion, they don't mean it in the way that random people on the street mean it. Spontaneous abortion is like a miscarriage type of thing. Yeah, I'm not gonna go off on this tangent. It is just the lingo is different. So when I say abortion, I don't mean that this lady walked into Planned Parenthood and got an abortion. It's a different it's a medical term. So you're prescribing opioids and she wants to continue them, and for some reason the taper is just not working and you absolutely can't taper her off. You've got to watch out for a variety of things in the baby, like decreased IQ, and impaired fetal development. It's gonna be tough. I'm gonna tell you. You gotta try your best. Why don't you engage in some of the other non-opioid treatments for pain to see if you could taper them off? Who wants to name the two specific ones that I named earlier? Okay, you could try physical therapy and the brace. Does that sound? You could try steroid injections. There's alternatives to opioid. All right, so let's see. If you are continuing a pregnant person on opioids, you got to drug test them more frequently. Now, your patient has become ever so much more complicated in that you're testing them for opioids and their UTOX comes back positive for marijuana now. Now, when I said before that you're the doctor and you want their drug test to come back positive, I meant for opioids. I didn't mean you want to come back positive for like cocaine and everything else. So this patient, you wanted it to be positive for opioids because if it wasn't, she'd be selling them. But now it's positive for marijuana as well. So what do you do? You guys just don't do anything and
I'd
Is
say
anybody still here? Come on, wake up.
I'd say at the very least confront them.
Well, yeah, you gotta be like, yo, positive for marijuana. The answer to the question is it depends on. Oh, my kids are running out in the street. Don't worry, there's an adult with them. Okay, it depends on the organization that you work for. Some organizations don't enforce it, but I'm pretty sure that the federal government mandates that you get them into a drug rehabilitation program ASAP. Good luck with that because a lot of people will not go. You've got to drug test them even more frequently. Call your social worker, get them signed up for extra help. The more support and the more checking in you do, the more likely they are to abide by the treatment recommendation. All right, so for the, oh, this is just going to be so important, so I'm asking again. What are those two words? One starts with a G and one starts with an E, and they have to do with the risk factors for opioid use.
Genes and environment.
Yes, genes and environment. All right, so you're talking to the patient. How do you assess the genes part?
You ask about like family history.
Yes, so I will simply just tell you the answer to this. The big risky things that contribute to a higher likelihood are going to be the genetic factors like the family history of substance use, including prescription drugs, illegal drugs, and alcohol, a personal use of any of those things. And the environmental factor would be a history of pre-adolescent sexual abuse. So that is an environmental risk factor that contributes to the use of opioids. You have to ask these things. In my daily biz, I ask people this constantly, but I understand if you're going into surgery, this might not be something you typically talk about. However, if you're going into surgery, you're going to be prescribing opioids, so you should be talking about this type of stuff. Okay, now another thing is if you're prescribing opioids, if you want to think of from a medical legal standpoint, what is something, so you're making sure your patient's taking it and not selling it and they're taking the right amount. What is another medical legal thing that could get you into a lot of trouble? And I'll give you a hint.
Driving while under the influence.
Yes, thank you. Driving. So if you prescribe somebody opioids, you have to ask them if they're okay to drive while they are taking them, how they feel. You have to warn them not to operate heavy machinery, but I mean, people are on painkillers all the time and drive. You can actually recommend that they go to the DMV and ask for an assessment for their ability to drive while on these drugs. Okay. The federal laws that it seems like I am the only doctor that follows sometimes are that if you are prescribing a controlled substance, you have to check in with that person every 3 months. I tell all my patients this, and they say, well, so and so prescriber down the street prescribes it to me, and I haven't checked in with them for 2 years. Well, that's great. They're going to end up in jail, but I don't particularly want to, and I don't want you to die. So we're going to go ahead and follow the laws. And those laws state that if you're getting a controlled substance, you have to be seen in real life, in the corporeal form, in 3 dimensions every 3 months. Not on a flat screen on Zoom, not over the telephone, in real life. Now, you can check in with me virtually every month. In fact, you have to because to prescribe opioids, federal law states that you can only prescribe them 1 month at a time. And I know some regions that will weirdly only let you do 1 week at a time. So that's good because you need to check in with your patients on these medications for their safety. It just boggles my mind that there's so many prescribers out there that prescribe these things and don't check in with people. Anyway, that burns my biscuits, but we'll go on to The FDA definition of opioid tolerance. Okay, so patients are considered opioid tolerant if they're taking for 1 week or longer at least these 30 milligrams daily of oral oxycodone. They have the dosages for other opioids as well on here. For example, a transdermal fentanyl patch. Ugh, I don't know. Fentanyl is just scares the crap out of me. I never prescribe any of this stuff. This is like serious, but there are people that legitimately are in pain and need it, and so it has to be done, right? And then another example of tolerance as defined by the FDA is oral oxymorphone 25 milligrams daily. So you can look up this chart and see if they have reached that threshold. I don't think that we went over the most, well, probably the most important part of all opioids is what is it about opioids that kills you? Do you dance yourself to death?
I feel like I saw an Anki card one time that said it was respiratory depression.
I think that you are a genius because that is literally the answer. It is respiratory depression. That is what kills you when you overdose on opioids. And that is why it's important that if somebody's not breathing, and honestly, okay, so I have to have this disclaimer that this isn't medical advice, and that my medical advice is only for my patients and it's all specific. But that being said, the risk benefit ratio of Narcanning somebody, it's probably not going to do anything negative, but it saves so many people. If somebody around you's not breathing, Narcan them. I mean, honestly, like even if you don't think they're on drugs, again, that's not a medical recommendation, but so anyway, if you find somebody that's not breathing, you give them the Narcan every 2 to 3 minutes until emergency responders are there. And a less serious, but still kind of horrible side effect of opioids. What now? Okay, I know you guys maybe haven't yet gone to medical school, but this one, every medical student knows what is like a big side effect of opioids. Besides the respiratory depression that kills you, that's obviously like the big one to watch out for. But this one's way more common. I don't know a single person who has taken an opioid and not had this side effect. The answer is constipation. And so I liked Senna, but the courses that I took said that opioid constipation is pretty serious. You're probably going to need a stimulant laxative to treat that. So if you are prescribing to your patient these opioids, in addition to all the things that I've named so far that you got to do, like the drug testing and recommendation to rehab if they find marijuana and everything I named so far, you're gonna have to prescribe them a laxative. I've never seen anybody have opioids and not have constipation. Okay, another thing. Oh, and besides telling them to go to the DMV and make sure they can drive, another thing you have to do, and this is not, you don't have to have gone to medical school to figure this one out. You want to make sure, A, because you don't want anybody dying, your patient or their brother or anybody lives in their house. And B, you don't want any random getting a pill bottle with your name on it. How do you prevent other people from getting their hands on these medications? You know your patient isn't selling them. Do not overthink this. It is a very easy answer. What do you do with your valuables at home if someone is going to steal them?
You put them somewhere where other people won't see them or find them.
Yes, you are supposed to tell anybody you prescribe opioids to that they have to keep them in a lockbox. And random fact, in the controlled substance forms that I have, It states that you're only to take them as instructed. I will give you an example. If somebody cuts up their tramadol, it'll cause a stroke. Just take them. Don't snort them. Don't crush them. Don't cut them up. Don't do parachuting. You guys can Google that later. Okay. So let's see. Marijuana. Methadone, buprenorphine, naltrexone. So do you guys remember from earlier when I was talking about agonists and antagonists, what the buprenorphine is? Anybody there? Is it just frozen?
I'm sorry, Dr. Waggel, could you repeat the question?
What was buprenorphine? It's Suboxone. It's a partial opioid agonist. That's another treatment that you can use. Okay. Naloxone, naltrexone, opioid use disorders. And then you have to check in with your patient frequently. You have to have the contract. Oh, it's also important to have them have the Narcan, but also, again, this is another question that you don't have to have medical school training. It is like a common sense kind of question. Who needs to be trained in administering the Narcan?
Nobody?
Well, that's actually, that makes, yeah, I know. You just stick it in their nose and you press like that. But I mean, I get the point I was getting to is that you need to ask your patient to explain to their family, this is the Narcan. You need to give this to me if I'm passed out or it looks like I'm not breathing or whatever. Because telling the patient that that's what it does is great, but if the patient isn't breathing, how are they going to go to the other room and take out the Narcan and put it in their nose, right? You catch what I'm saying? It needs to be someone other than the patient because the patient is incapacitated.
Yeah, I like have some friends who are also like RAs on campus. And they've been learning the last couple of years, like I think since last year, they've included like Narcan, like how to administer it into their training. Because, obviously like you're living around these students, so it's
Right.
helpful for them to have.
That is genius. Wonderful. Okay. You guys have your opioid patient and you've learned all the right things to do. What do you think? Are you ready? Are you ready to prescribe opioids?
Maybe in like 8 years.
Yeah, it's gonna be a while. Okay. Any questions about any of that fun stuff?
I was wondering if there's ever a scenario where, oh, I forgot. Where Narcan like doesn't work. Is there anything else that we can do? Like maybe administer like another dose or?
Yeah, you're supposed to administer a dose every 2 to 3 minutes until the emergency responders are there. You as a civilian, you as a doctor, so the way I've been teaching this is like you're like a primary care doctor in these cases. In emergency medicine, you would engage in the ACLS, Advanced Cardiac Life Support protocol, which was beyond the scope of this lecture. And quite frankly, it has been a number of years since I memorized it, and I'm not prepared to teach ACLS class today. There are other things that you can do, yes. You as an emergency medicine physician, you as a feel like primary care doctors should be ACLS certified too. But you as a civilian, your job is to give the Narcan every 2 to 3 minutes until the first responders get there. Make sense?
Yeah, thank you so much, Dr. Waggel.
Well, I think you guys learned a lot. What do you think?
I also think we learned a lot.
And anybody who attended can put on their log that I'm so proud and happy to call you my student, and that you are one of the few who came live to the lecture, because I like interaction, which is hard to do when people watch the lectures delayed later on. I mean, unless you're watching this on YouTube now and you're yelling at the TV or at your phone, like out the answers, then that's great. But I do like a little interaction. So I appreciate everybody that's here. You guys did a great job. Give yourselves a round of applause. Yay! Okay, so this will be on later. And everybody who was here gets a special note in your letters and, like, what did I say? 10 bonus points on your test? 1,000 bonus points?
I think 10 sounds right.
Actually,
sure it
Dr.
wasn't?
Waggel, I think it was 1 million.
Yes, it was 1 million. Everybody gets 1 million bonus points. Okay, it'll be up on YouTube later. And I appreciate everybody's attendance. Thank you very much. Don't do drugs. Bye.
Thank you. Bye.